Well, we're excited. In the next couple of weeks, we're all going to be together. Hopefully, as many of us as possible is going to be here, be in Phoenix, and we can chat and meet together. I'm really excited about that. And today, Virna is going to talk to us about one of her labors of love in looking at suicide in collaborative care and in integrated care settings. I love the fact that she's worked so hard to decrease the idea of that's not something that we do in primary care, but that we suicide treating and screening for suicide is a big part of what we do. So I'm excited about her sharing her kind of newest thoughts with us today. And
Well,
I will
good.
let you take it away, Virna. It looks like you were able to share your screen.
I was able to share my screen thanks to technology. I am going to give a. Oh, oh, I think someone's got some feedback there. Little bit of a disclaimer. When I said in transition, I should have said still in the back of a lift to an airport. So to try to get a flight that was canceled and moved. So apologies for that. So really excited to actually talk about a couple of things that we have worked on and really been thinking about suicide safer care in collaborative care. And I have thought for a really long time that collaborative care is actually a really appropriate model for people at risk for suicide because of the high touchness, because of the flexibility. I can talk to you every day and review a safety plan, do a Columbia scale, and also because we've seen such an increase in numbers. Like we just looked at something recently and talked to some other organizations, and like 10% to 12% at any given time of my collaborative care population is flagged with some sort of suicide risk. And so I think it's important to really think about how we're caring for people, how we're identifying people, and really thinking it through and putting in a pathway. So a couple of sort of new thoughts as we've been thinking about suicide safer care. One is that it's really important to have a pathway as opposed to like a policy. Policy more, we do pathways. They are care. And when we think about provider, you think about it like other illnesses where not everybody needs the same level of care. And you think about your workforce and how you need to try to make sure that everybody gets the right level of care. And so as we started to think about that, we started to think about, well, our populations of patients at risk for suicide really need different levels of care. And so the best practice now is really to stratify them. So we used to think about suicide like you're either at risk and you're kind of flagged and you're on a pathway or you're not, right? It was sort of this very, you're in or you're out kind of thinking. And I think we've really transitioned now to really think about stratifying and coming up with different ways to classify and stratify patients who are at risk for suicide. And so we started to think, what are some of the best ways to do that? And what are most people in the field doing around suicide safer care? And we started to think, well, if we switched it to tools like the Columbia scale or the ASQ, so thinking about then we could use the Columbia scale as an example. It's in most EMRs, most organizations use it, and then thinking about how we train our people really into categories. So the that we sort of affect primary care is really your you have your yellow, your orange, and your red patients. So I might have lost my screen, but I'll pull it back up. And so the idea is, how can we do a pathway that models what we're already teaching people on the Columbia scale? And so then stratifying patients so that you could do something with your yellow patients, your orange patients, and your red patients. And this would allow them to use the tool that they were sort of already using. And so we developed a pathway that really mirrored the Columbia scale. And so I'm going to share my screen again so that you're able to see what we developed. And I'll kind of talk you through it. And so when we think about what the new pathway looks like, this is actually what we developed. And so if you look, we modeled it after the Columbia scale colors. And essentially people who have intent are the red, people who may not have intent, but you're a little worried about, and then your yellow patients. And then we started to think about having a low level of patients and historical patients. So patients who are historical are the ones that maybe had some risk, but are no longer really at risk, but we know theoretically they're more at risk their entire life, right? And so we want to know about them, but we maybe don't necessarily need to have them on a pathway. Maybe we do something different in, like maybe we ask them about suicide directly twice a year, or as part of a screening, they get a suicide question. So we're doing something a little bit different. It's on the problem list, but maybe resolved. And then for our yellow patients, then maybe what we're doing is we're making sure that we're in contact with them, you know, every once a month, that they're getting a Columbia scale, that they have a safety plan that has 988 and a lifeline or lifeline, and maybe Now Matters Now. And then our orange patients maybe have a Stanley and Brown safety plan, and we're making sure that we talk to them, you know, every 14 days, you know, so at least twice a month. And we're making sure they get a Columbia scale every single time. And then our high risk patients, we thought about this because one of the things we knew was that some people maybe have intent and we're going to fall in the red, but we wanted to still keep, maybe they didn't need an alternate level of care. And so we actually pulled the question from the ASQ, basically, are you thinking about killing yourself right now? And added that, so that there are some patients maybe are high risk, we're going to keep them, they have some intent, we're going to make sure we talk to them every 7 days, and we're going to have a safety plan with them, they're going to have an emergency safety plan, they're going to get the Columbia scale every time. And then we tried to think about psychiatric consultation in collaborative care. So our high risk red patients, it's every week, right? We want to talk about them every week. We really want to monitor them. And then maybe your other levels, your orange, it's, you know, once a month. It's historical, maybe, you know, at the start to make sure we didn't miss anything. And so really started to then give organizations something to say, this is how we're thinking about our populations of patients at risk for suicide. This is how it fits into collaborative care. This is how we're thinking about how to care for them, because not everybody needs same. And also it's you hear from staff a lot of times, oh, why do I have to do the Columbia scale on every patient on the pathway when maybe that's not what you know, all patients need. So I've done a lot of talking. I'm glad to share this. I was going to send it out. I actually asked for some feedback for folks, and I welcome anyone's feedback. I still view this as a, you know, as we all know, everything we do is always a work in progress. But really starting to think through some of this. So glad for feedback and glad to answer questions, and also glad to share copies of other pathways, but this is the one that we're really leaning towards. So I'm going to stop there and let people digest all that information and maybe answer some questions.
Hey Virna, this is Stacy from Maine.
Hi,
Um,
Stacy. How are
so
you?
I guess this is just a comment, and I'm looking for you to check my thinking here. But it sounds like these pathways and working with or taking care of this population really fits well with CoCM. Would you agree to that? It sounds
I
like a
would
nice
totally
package.
agree to it because
Yeah.
when you think about it, right, it's so high touch so that if I have somebody, I can call them, every day or every other day to check, ask them if they're safe, review a safety plan. And, the average DBT skill is 6 to 8 minutes. And so I could call in a follow up and teach a DBT skill. I can actually pull my hair in a ponytail and we could put our heads in ice water remotely together, right? As part of a follow-up call. And so, absolutely, I firmly believe that collaborative care is pretty effective for people at risk for suicide. And I've seen it work. And I can tell you a little bit about what we've learned. I don't think I have my data here, but I could pull it up. We actually have learned that we can reduce risk. So the other nice thing about stratifying is that if people are getting better, like if people are flagged or unflagged, they're still historical and then they're not marked. So you don't want to miss those patients. But also you want to know, are we taking people from high risk, to a lower risk to at risk, and then eventually down to historical? Like how often does that happen? And then we're tracking that. So what we're seeing is that we're reducing a lot of people down in risk through collaborative care. And so this gives you a nice way to measure how many people are high risk, how many people are at risk, how many people did we lower the risk scores for. So Stacy, that was super long-winded, sorry.
No, I appreciate it. And all of that information is very helpful. Thank you.
And so I think if people aren't stratifying the population, then I would start to think about what that looks like. So one of the reasons that we put the ICD-10 codes in here is because a lot of EMRs don't have the ability to stratify, right? They don't have you're flagged or you're marked or you're not, or you have a suicide episode in Epic, although now people are doing like high risk, at risk episodes. But so we put the ICD-10 codes in here so that at any given time, based on the ICD-10 code, you would know how many people you had in a certain risk level. So it was kind of our way both of encouraging people to put suicide on the problem list, which I firmly believe you should do, so that you have a sense. And also it's a huge quality issue, because if you don't know someone's at risk for suicide and I'm caring for your patient, I may ask different questions or make different decisions based on that information. But it also gives you structured data, like so that you know how many people in your organization are even at risk for suicide. Like you don't know that unless you have a structured data way of looking at it. So it's important to use the ICD-10 codes, but we tried to pair them here for that reason as well. I can also tell you what we did find interestingly is, clearly I'm super passionate about this work. And I thought we did a really good job training our staff, our team, our master's level clinicians at Concert, in particular, on suicide safer care. And what we found in like 220 episodes is I was like, gosh, we're winding up with so many high risk people, and I'm not really sure that's right. And so I have someone on my team who is like a super subject matter expert, trained with Linehan, and so she did specialized consultations, and we found that like 100 and some odd of them were actually classified wrong, that people classified them higher than they needed to be, because they still didn't really understand the idea of risk stratification or understand the idea of what really puts someone at risk. or they just thought everybody who talked about suicide and even had thoughts of suicide or a plan how to die by suicide was automatically high risk, even though they might not have had intent and had some protective factors. And so it really took that second layer of education. And after that, we found people were much better. And so I would strongly encourage you to sort of keep that in mind as you move forward doing this work, that we had to put that extra layer of training and supervision in.
That makes sense. Brenda, did you say that you found that people rated risk higher than?
Yes.
Yeah,
Yep.
that makes sense. I think
Yeah.
some of it is people are afraid too of not, indicating something.
Yeah, they're afraid, and they really, I know when I was trained, right? It was like if somebody had thoughts of suicide and they had a plan on how to die by suicide, then it was like that's your ticket to the emergency room, right? Whereas now we know that it's about intent, right? And we know a lot more. And so I think people just don't get the training. When we did this survey, don't mind my airport noises in the background here, I'm sorry. They've decided they need to share information suddenly. So is that when we did this primary care project, so it's like 32 states now, 44% of the behavioral health providers in primary care said they didn't feel comfortable or competent to care for somebody at risk for suicide when we asked them. And so that kind of tells you, the level of training.
It seems like a high percentage.
Yeah, but I would agree. And when you think about safety plans, so when we look at safety plans, and I'm in Texas now, and I looked at safety plans that social workers did in a community health center, and none of them were quality safety plans, not a single one of them. And I think the training around safety planning also, that you need to really think about like quality safety plans and what makes a quality safety plan. So like as you go forward and think about how you're caring for your people at risk for suicide, if I'm on your quality team and I do a chart review and somebody's at risk for suicide, I should have a separate tool that I fill out. What makes a quality safety plan? Right? How do we look at the safety plans that we're doing and say this is a quality safety plan? And so when I look at it, I think, is this, really personal, right? Is it something very specific to that patient? Is it an activity that can happen 24 hours a day, 365 days a year? So like going for a walk, right? Well, maybe that's not an option at 2:00 in the morning, right? And then also if it's people to contact, did we actually call those people on the phone, and did we talk to them that are on the safety plan? So those kinds of things that really make a quality kind of safety plan.
Virna, can you say more about you mentioned in the different levels, like at one level it was safety plan that included XYZ, and then the other one you said a different safety plan. Can you comments on those two?
Yeah, so there's some organizational decisions around, how you want to do some of these. So I like the Now Matters Now safety plan that's on the website, their emergency safety plan. I feel like people who are historical, benefit, like we all know what to do if we catch on physical fire, right? So everybody should know what to do if they catch on emotional fire. So if you're historical risk, then you have the information. I mean, I don't need to do a Stanley and Brown full safety plan with you, but I'm giving you this safety plan should you catch on emotional fire. And so some organizations say for our historical patients, for our yellow patients, then we're going to do the emergency safety plan. We're going to give 988. We're going to give Now Matters Now. And then for our orange patients, we're going to do the Stanley and Brown safety plan as sort of a primary, in addition to 988 and Now Matters Now. And then for our red patients, we let them know what to do if you're on fire, and we build that into a broader Stanley and Brown version safety plan. So it's a little bit, but a lot will actually do that. If that answered your question, Patty.
Yeah, thanks.
And if
And I
folks
I put a
aren't,
link to that in the chat, the Now Matters Now safety plan. It's pretty awesome.
it is pretty awesome. It's actually, I just put it up too. And I really just go over the, like, what to do if you're on emotional fire, right? So you've got a couple things you can do. And stop, drop, and roll, because it turns out that works for emotional and physical fires. Tish is laughing, but yeah, it's true, right? If I stop, drop, and roll, I'm not dying by suicide. Yeah.
Someone who's done a lot of DBTs.
Yeah. Yeah, for sure. And so I think it's helpful, to think about what it looks like. And so the PCPs, yeah, we'll send the slide out. I'll actually send it on the CFHA, or I'll send it to Diane or Tisha, and they can send it out to people on this. So there is a training for primary care providers. We've actually trained over 3,500 now. And it's basically what to do in a 15-minute primary care visit, like how to care for people at risk for suicide. And it's funded by Centene, so it doesn't even cost anything. If people want to train primary care providers in your organization, then you can reach out to me and I can set that up. And it's really helpful, because if you think about basing it off the Columbia scale in particular, this is what I do for my yellow patients. This is what I do for my orange patients. And a lot of that can happen in the primary care visit. And we make comparisons to chronic illnesses, to other chronic illnesses and what they do. But also to get people think, like I always say, I'm diabetic. So when I go back to the primary care provider, like certain things happen because I'm diabetic, but we don't put processes in place for what to do with follow-up for the suicide. If I'm identified as being at risk for suicide and I get referred to see Tisha, who is amazing and a fabulous clinician, right? So even though I'm in this amazing behavioral health care, somebody should still ask me when I come back to primary care, right? Even though I'm a diabetic and I'm seeing the most fabulous diabetes educator and endocrinologist, and I'm really super connected, when I come back to my primary care provider, they ask me about my diabetes. They look at my A1C. We talk about the progress. And so primary care at the very least should be asking if someone's safe, right? So that there's these processes in place to follow up.
Yeah, I think that's a great analogy, because I know in my experience of seeing, like, in notes, it's like person is being followed by mental health, right? Like, oh, they've got a therapist, so I don't have to ask about these questions.
Yeah. So yeah, and I always make the analogy, right? So then, then I don't need to know what the A1C is, or I don't need to know if you're taking your metformin, or I don't need to, like, we would never do that. So I think, given what some of the requirements are now for, like Joint Commission in particular, because there was a death of a young adolescent on an inpatient unit and they didn't report it and they didn't follow some processes. So boy, if you ever want to piss off Joint Commission, that would be the way to do it. And so they're on a pretty good tear now, really talking about suicide, asking to see pathways, really looking at this. So like, if you're not really thinking about your suicide at risk as a population, and you don't have a pathway and you don't know how many people you have, then that's something really to think about as an organization, like what that looks like. And it's not as much, like some of you have probably heard zero suicide, and I think it's important to take an organizational approach, without a doubt. And we have lots of information on that, and how do you train and what does that look like? And of course, we lose multiple healthcare providers a day to suicide. So certainly not an issue. I mean, it's up to like one physician a day now, not to mention nurses and behavioral health providers. So, it's an organizational process. But in terms of just patients, if you're not really thinking about it, like if you don't have a pathway, And then to really think about, this helps you identify what patients go on your pathway, like what patients are we doing something different for, and what are we doing, and how do they get off the pathway? Like, I don't reduce a risk level. It's not an independent decision. It's the team for everybody who cares for that patient, because I just have had too many times where something was missed in the chart, or somebody had something to add and we lost someone to suicide. And also, nobody gets lowered risk level if they've had a transition within 30 days, if they've had a med change, if they have any psychotic features. That is, you stay at the risk level that you're at. I don't change them. But I'm glad to share this. I'm also glad to get feedback. I'm glad to talk people through like what it would look like, or answer questions about what it would look like in your organization, or how to do it, or train providers. I've probably overwhelmed everybody.
I would love more information on that, Virna. This is Stacy again, but just to hear more and see what that could look like.
Yeah. And I think, thinking about the tools that you're using. So I like the ASQ better for children and adolescents. Like, I know they just put the Columbia scale out for children and adolescents. I actually have it here in this presentation, but I like the ASQ better. I like the ASQ better because it actually has, a guide for children, and has a guide for parents, a script for nursing. I think it's easier to use, and I like question 5. Question 5, basically, are you have thoughts of killing yourself right now? Well, that's easy. If it's yes, I go one direction. If it's no, then I go another direction. So I just think it's easier. So the Columbia scale for children, I don't think is as evidence-based, and it's a little bit harder to use. So me personally, but you could, and then you have the color coding as well. But for the adults, I think it's a really good way to start with the Columbia scale, because then you can develop your workflows off of the colors on the Columbia scale, and it makes sense to your primary care providers. It makes sense to your behavioral health people. It's concrete. If this, do this. If this, do this. And it's just easier to base it off of. And so that's why I kind of recommend it. And then I change question at the bottom and do, because I want to know the first time I talk to you in your lifetime, like, have you ever? And then ultimately, I want to know in the past 3 months, because then maybe I could lower your risk. But if you're high risk, where I'm tracking you, then I want to know since the last time we talked. So I do change the last question based on those 3 scenarios. And if somebody has not been at risk for 3 months, then you could lower their risk. So yeah, just reach out to me, Stacy, and I'd be glad to hop on a call with you or help you however you think I could. Any other questions, comments, thoughts? I think you can tie this to your psychiatric consultation, put in processes for collaborative care.
So for me, as far as like thinking about screening, like very basic screening all the way, through, my organization has decided to do the PHQ-2, which I feel like can really make it difficult for us to get to some of those questions. If for some reason we don't ask those 2 questions well, then we don't go to the 9. We don't ever ask question 9. So just kind of thinking through ways
Huge problem.
Yeah.
Huge problem. And I would say more and more, I think that it's come out that we know that people that answer yes to question 9 are more likely to die by suicide, right? But there's also some literature that says like it's not the best in terms of asking about suicide, right? So if, I was talking to NIMH the other day, and they're really saying like 10 and up, you should ask pretty routinely and specifically around suicide. So I don't know if you saw the latest number for the adolescents. It's like 10.2% will have a suicide attempt. Like, that blows my mind. And so, for the PHQA, so this version that I'm showing here actually has the ASQ built into the bottom. I love that. I love having the first two questions of the Columbia scale built onto the PHQ-9, and you just ask them no matter what. I also think, we forget about anxiety. Like, the US Preventative Task Force says now we have to screen for anxiety, which I think is great, because anxiety is a huge risk factor for suicide, and most people don't even make the connection. And so we don't, like, if somebody scores positive on the GAD, we don't think to even ask them about suicide. And so I think it's really nice to just put the tools, like the Columbia scale, at least the first two questions on the bottom of that, and ask it fairly routinely.
Yeah, so something like almost hitting those first two questions at least like annually.
Exactly. Yeah. And the thing about screening is, it doesn't make sense to do depression or anxiety screening every time, right? Or intimate partner violence, or, whatever the screening is, social determinants. If you have a thoughtful screening process that we do this once a year, or twice a year for historical patients, once a year for everybody else, this for, for our prenatal patients, we're going to ask it again, like that if you have somebody getting out of the hospital, we ask them. So if you have a thoughtful process around all of the screenings, and then people understand why you're asking, staff understand why you're asking, you're way better off, and it's going to be way more accurate. So like, you don't see adolescents that much for the most part. And so ask them when you see them, because their risk can change so drastically, and it's a good practice.
Yeah, and Patty added she thinks this is really important to continue discussing, and I agree. As I was kind of saying at the beginning, that again, CoCM has kind of gotten pegged into the mild to moderate, and you don't. All these other people I need to fall off your roles, and I think this is a really important use of a systematic review, and like you said, Virna, the ability to contact people frequently and to be able to check in, and it's such a great way to use those resources.
I would also say that, we would think that the people who answered yes to question 9 or were flagged for suicide would have the higher PHQ scores. It turns out they don't. That a lot of people score on the suicide question or are flagged for suicide risk and have baseline scores of, 12, 13, 14. They don't all have scores in the, 20s.
Are there anxiety scores higher though? Do we know that?
When I actually looked at it, it turns out that they were a little bit higher. Interestingly, and I haven't had a chance to dig into it, is I found that my anxiety patients actually were not getting better at the same rates if they had a positive Columbia scale, that it was very different from my non-suicide risk population by a significant amount. And so I'm still trying to dive into that and figure that out.
And I would wonder, like in our chronic medical condition patients, right, kind of the demoralization, grief loss issues more. I mean, it doesn't necessarily show up as depression. They're just lost so much, and a lot of times it doesn't, it doesn't feel. I hear all the time, I don't know. I don't want to wake up. I don't have any reason to get up, but maybe they don't,
right. Or the social determinants.
Or,
remember, a lot of people that die by suicide don't have a mental illness at the time of death. It's the social determinants that are these huge risk factors.
Yeah, loss of relationships,
financial, housing, all of those things. Yeah, that could be, Laura. Yeah, it could be. I think, there's lots we're learning, and I think, what you're hearing is very different than what we did even, a year ago, because we're just learning so much about how to think about different levels and different touches for different people. But I'm always glad to talk about this. Clearly, you can tell.
If you could, I know you said you'd share the slides. Any of the data would be helpful too, to see, just as we talk to our own systems about what others are finding, would be helpful.
Yeah, I can certainly share. I can, actually, we're just looking now and trying to figure out what that looks like. I think I might have some. Yeah, so I think it's interesting to see, you know, what we're learning. So this is actually what we have by level. So this is only 3,500 episodes, but sort of where people, you know, sort of at risk, high risk, and historical. So a lot of people were sort of in that at risk, sort of middle bucket when we kind of looked at them. And then when we looked at reducing risk level, that we were able to sort of take people down to being historical at discharge. And this is when we just started to look at it. So it's 5,200 patients that we were sort of able to bring down. And you see that going up was us doing some learning around training and different things. So really thinking about, you know, what that looks like. And then this is actually data around the changes in the risk flag for people that needed training, so that you can see where people were initially and then where they sort of were at the end.
Virna, do you have any good tools for violence assessment? Looking at the evidence base, it seems there's a lot of parallels with suicide risk, in particular intent and behaviors being some of the biggest risk factors, but this is something that comes up often. You know, should we be screening for that, especially to protect our staff? And if so, how best to do that?
So there is a training this week, actually. A colleague of mine, Bart Andrews, who's out of Missouri, actually does a really nice like homicide, suicide risk assessment. He's doing a training for me this month, Laura, for CCMP in New York. I could actually share that link. I'm watching Danny look off into like, hi Danny, she's such a sweetie. I miss you. And so really I could share that link and people could join, but he does a really nice job at that. And so I think we have a lot to learn there too. But yeah, I totally think we need to, and people do use the Columbia scale for asking about violence to others. I think it's better than nothing and certainly a good conversation starter, but I would totally think we have a lot to learn. So you and I will come out of that with some ideas, I'm sure.
Sounds great. Definitely send that that link along.
Yeah, you should have it, but I'll share it with the collaborative care group. With this group, to be able to do that. Actually, I'm not sure when it is, but we could figure it out, and I could share it.
Do you know if there's any, and maybe you already mentioned this, but research papers or anything to show the efficacy of CoCM with the population?
Yes, absolutely. There's some out there. I've actually written some about it as well. So there definitely is. And I know the AIM Center has as well. So there's definitely some things out there for sure.
Thanks.
I'll actually put the link to that New York training in the chat so that people can have it. I'm sure New York won't mind if all of you join in, if you're able to. They can just blame me.
We're not too rowdy. Well,
yeah. Well, you know, certainly anybody has any questions, comments, feel free to reach out to me. I'm even at CFHA if you want to sit down and have a cup of coffee and sort of talk of, you know, through what you're thinking for your organization. I'm super glad to do that.
out.
Thank you so much.
So I was wondering for you, Virna, like if someone's saw this and it's like thinking, okay, we do some CoCM, we've got some stuff going, but we really want to really start incorporating this. What do you think are the first steps?
I would say to really think about how you want to care for your population of patients at risk for suicide. Like, what would be excellent care? What would we want to happen? We would want to do the Columbia scale. How are we going to identify people? How are we going to care for them? How are we going to know they're getting better? And kind of think it through at that very basic level and start there. And I do have one of these for non-collaborative care as well. That we did. It's just taking out the PC consultation and some of those pieces for your non-collaborative care populations, which I could share. I have to find it.
Yeah, I was thinking I just finished going at a meeting with like a group of people who are working directly with physicians for mental health for kids. And, some of those physicians will have integrated care, some of them won't. So thinking about how this could translate to primary care settings that don't right now have embedded behavioral health providers.
Oh yeah, because you're yellow and orange. And so I do a lot of work in Montana, Wyoming, and I just assume there is no behavioral health provider, and I teach them how to manage their yellow and orange patients. All right. Well, I guess we'll
Thank
see
you
everybody.
so much, Virna.
No, thank you. It's always fun. You guys are the bomb.
I put a shameless plug in the chat. Virna, me, Laura, and Monica, who I think was on at least at one point, are doing an ELO at the conference, and we're really excited about it. I think it's going to be a lot of fun talking about this idea of populations and how do we fit our services to meet these groups of patients that we want to serve. And so,
and we're giving away fruit snacks. So how bad could that be?
Yes, we're going to have a lot of fun. We're going to snack and really kind of stretch some of these ideas and kind of think about it. So I'm really excited about that. And I think we've got some great collaborative care, other trainings and areas that are happening all throughout CFHA. So it's going to be a great conference, and I think probably historically one that had the most programming, thinking about all these different ways of doing things. So very excited.
Great. And thank you all for my bumpy transition today, going from a lift to the airport. So apologies for all of that drama while I was doing this.
Thank you too. Diane unexpectedly wasn't able to be here, and then I was in that other meeting. I'm like, this is going to be a fun day.
Fabulous. Yeah.
We pulled it off.
Thank you, everyone. Have a great day. Bye.
Bye.
Thank you.